Good evening. So from obstetrics, we're now just moving on to a few gynec scenarios. Now my patient is a 33-year-old lady. She's para 1 live 1. Her last child birth was 8 years ago. She's slightly overweight. She's a known case of PCOS. Now she's come with complaints of irregular bleeding per vaginum since 1 year after delivery. So now almost in 7 years, she's been having irregular bleeding. Now she's been seeing someone who's been given her Orgamed, which is medroxyprogesterone and Femilon, on and off. She's not on regular treatment. She takes it sometimes, doesn't take it. Now she has come to us with her bleeding, which began 17 days back, and it's still continuing. She was started on Meprate, medroxyprogesterone 10 milligram, BD, since 1 week. And just the previous day before presenting to us, she's gone and seen the doctor again, who's also given her Novex DS. A speculum vaginal examination was done by us, and that was within normal limits. Now, how would you normally proceed? Maybe from Shamla, madam, we can start. Madam, would you do a TVS endometrial sampling or straight away treatment? She's been bleeding for 17 days. Somebody's already put her on medroxyprogesterone and Novex
irregular
DS.
bleeding may be due to irregular use of hormones. Okay. So complete examination of the patient, do a vaginal examination, do a TVS to rule out any pathology. If there is any not any pathology is present before endometrial sampling, you can put her on cyclical hormones.
Okay.
In
So,
spite
madam,
of
you
cyclical,
are essentially saying that the first thing to be done would be to do a transvaginal ultrasound after an examination.
after physical exam, very, very important.
Correct.
After physical examination, proper history, just ask her whether she is on any drug which can produce bleeding, isn't it? Sometimes she may be taking some drugs which can precipitate
No, the
bleeding.
history was more or less like she would take Femilon or something for some time, her bleeding would be controlled. Next 3-4 months, she would think that, okay, now
No,
my
she will-
cycles are regular, then she'd leave the hormones and then again back
Like
to
it is
hormones.
irregular use of hormone is the most common cause of irregular bleeding in our present scenario.
Okay.
So when they bleed, they will take this medicine for 2 or 3 days, then they will stop it again, they will bleed again, they will take the same medicine. So to go in the typical history, see what hormone she is taking, how long she is taking, any other drug which can cause bleeding.
Okay.
She may be on some other drugs for hemophilia or ITP that can also produce bleeding. So proper history is very, very important. Then do a physical examination, see whether she is anemic, whether she is gives the history is normal. Sometimes it may be whether she is doing her routine or she has to take leave or she has not attending her household. That means absolutely she is bleeding. Some patients will say bleeding, but she will be pakka pinker than me, isn't it?
Right.
Hemoglobin, no hemoglobin. They will give all these histories. So make sure, examine her, make sure she is not anemic. Local examination, vaginal examination, rule out anything. Then there sometimes there may be some intrauterine lesion which you can also do a TVS also if she is not bleeding that time. Okay.
So basically proper history, then you go for proper pelvic examination or general examination and also then followed by an ultrasound scan.
Then when she comes with profuse bleeding, a moderate to severe amount of bleeding, we cannot do a vaginal examination or we cannot do a TVS. Just start her on hemostatic progesterogens, norethisterone you start. When give her the hemostatic dose and then you maintain on 10 milligram daily.
Okay.
And during
I'll
this
just come to the treatment.
non-bleeding phase, you ask her to come and then again you can do the examination, TVS, everything.
Okay, so control acute symptoms
control
and then
and then
maybe
you
go in for an
examine the
examination later. Okay, that's fair enough. So basic thing is you take a proper history, you go in for examination, then you do an ultrasound scan. Another very important point, acutely bleeding, don't bother about all this. You try and control the bleeding and you can maybe do the examination slightly later. Now we've done the ultrasound scan for her. Endometrial thickness was 13 millimeter. The rest of the uterus is normal. I've only put the salient points here. Both ovaries are polycystic type. Dr. Sheila, what would you do next? Does this lady need endometrial sampling? What would be your method of progression?
She's a known patient with polycystic
Yes.
ovarian syndrome, 33
Yes.
years. I wouldn't, at this point, I don't think she needs endometrial sampling.
Okay.
Because 13 millimeter, and
Yeah.
this, I would just
But
put her on hemostatic put her on 19-not testosterone derivatives to stop the bleeding.
Okay.
Continue. I wouldn't straight away, unless, I mean, there are other risk factors like she's extremely obese. I mean, even 13
No,
millimeters.
she's just overweight, but she's been having this irregular bleeding from the past 7 years, even
Yeah,
on
but
and off
that's a known
hormones.
case of polycystic ovarian syndrome at 33 years. And I mean, it's unlike with a 13 millimeter endometrium in the I don't think there is a acute need to do endometrial sampling at the moment. And one more thing is, because she, I mean, irregular use of hormones, because most of these girls are, women are on medroxyprogesterone. Right. So I think it's very important that when we give them the hormones, tell them how to take it. Tell them that every alternate month, they should be getting their periods. That's very important. Instead of waiting for 3 to 4 months and then coming with prolonged bleeding, I think it's very important that they just take medroxyprogesterone every alternate month or so.
Correct. I think that's a very important point. You have to tell them that it's very important to get a period. They're more worried about taking the hormones. So if you make it clear to them that it's very important you get a monthly period, they will take their pills. Any difference
More,
of opinion?
Deepa, when you say this endometrial, this is 13 millimeter, make sure when she had this scan. If it is premenstrual, repeat your scan after menstruation and see what is the thickness. That is more important to say whether you need an endometrial biopsy or not.
Right. So you would suggest the scan immediately after menstruation or maybe on day 2, day 3 of her during her periods, next periods?
No, just premenstrual endometrium will be always thicker, isn't
Oh,
it? So
yeah.
if you want, you might, whether it is a PCO, whether it is a can see endometrium is in your mind. So you repeat your ultrasound after menses, after first week. Still the endometrium is thick, you can proceed with the endometrial sampling, no problem.
Okay. Now we'll just look at what are, yes madam.
We had cases of endometrial cancer in their 30s.
Correct, that's exactly what I wanted to bring about. Yes.
Especially in patients who
Right.
says they're having irregular bleeding for 7 years.
Right.
You assume that they're taking irregularly. Did you ask? How
Yes,
they were
I
taking
asked,
the
I
tablet?
asked, I asked.
How were they taking the tablet?
She would take it for say 2 months. The next
Regularly?
month, her,
Regularly.
2 months she would take it properly.
Okay.
And her bleeding would get controlled. Next month she'd think, okay, fine, now I'm getting a normal period. Then she'll wait for another 2 months. When it
So
again
what
becomes
happens
irregular,
what happens to the withdrawal bleeding? Is it normal? Or is it
withdrawal
excessive?
bleed is normal. She says 7 to 8 days and she's comfortable with it. But then now again, she'll have one regular cycle after that. Then she has another 2-3 months of amenorrhea. That's when she comes back to the doctor. So she's not been taking it like every month.
See, at no time this lady had it because with that history, this lady never had an endometrial. It's not sampling. It should be a thorough dilatation and curettage, fractional curettage. Or
Okay.
whatever you tell your hysteroscopy. See whether
Okay.
she has got anything inside.
Okay.
That is
So
your problem.
you are basically
Because
differing.
we have seen.
We don't know, madam.
Not only one. I had about 3-4 cases of endometrial cancer in younger patients.
Okay.
One unmarried girl, next door neighbor.
Do a repeat the scan after her periods, and if you find a thin endometrium after her periods, it's unlikely to have a problem. Now, she might be having a thick.
Maybe we'll just see what are the recommendations.
That is not for PCO.
These are the recommendations for endometrial sampling, which has come out just now by the FIGO has endorsed it and come out by the ACOG in 2013. Let's just look at what these recommendations say. Our patient fits into point 2. So I'll go to point 2 first. You consider endometrial biopsy in women with infrequent menses suggestive of anovulatory cycles, they say even before 40. Initial indications are if the woman is more than 40, if she has risk factors for endometrial cancer. Risk factors being she's obese, she's hypertensive, failure of medical treatment, PCO, exactly, and significant intermenstrual bleeding. For anovulatory women, they say you don't really need to wait to 40 years, 30 years earlier, go ahead with sampling. That's what they say, that's safer. So I think the consensus should be that if the woman has been having irregular bleeding for some time, you don't really need to wait up to 40 years. You should not be relaxed and wait back. Now, which would you prefer? Maybe Sheila Shenoy, madam, conventional fractional curettage or a Pipel?
Definitely the recommendation should be PIPL or endometrial aspiration. That
Okay.
is the thing, the in thing now. We are not going for the conventional fractional curettage has gone out of date. So
Right. Could you suggest something like Pipel is not easily available? So a lot of doctors come and ask, what do we do? Correct.
Carmen's cannula and aspiration
Yes,
is the
that-
one
that's
which
what I wanted to get
can
in.
very well do. So that
Simple
more,
thing. If you
can
can't
get
buy
more
the Pipel, don't worry. Exactly. Like madam said, you can use a Carmen's cannula with syringe. Number 5, what size do you use, madam? 4. So number 4, number 5, you can use it. Connect a syringe to it. Put it inside. Get negative pressure. You can pull out. You can get a tissue.
No, before that. No,
Yes,
no,
ma'am.
you won't get anything. You put your cannula, make a scrape. Scrape it with cannula,
Okay.
and then aspirate. If you put a 4 millimeter cannula and aspirate,
Okay.
nothing
Madam,
will
can
come
you just tell that to them? So she'll just tell you the procedure on how exactly it's done. Can
See,
you?
you introduce that 4 millimeter cannula into the uterine cavity, scrape the uterine wall just as you are doing this aspiration for your abortion, and then aspirate.
Then suck
if
it
you
out,
just
okay.
put a cannula and aspirate it with a 4 millimeter, nothing will come out.
Okay. So I think it is pretty clear on how exactly to get the sample out. So sensitivity of the Pipel in detecting endometrial cancer ranges from 68 to 98%, and you have similar detection rates even with an FC. So I think we'll all agree now we can move in for less invasive things. From fractional curettage, you can move into just a Pipel or use a simple Carmen's cannula.
But one Something more, if with your PPLE, you don't get a negative result. But the symptoms are there, and you suspect malignancy, better to go in for a diagnostic ureter.
So you're basically saying, madam, if there's a negative PIPL and you're still suspicious, go in for an
Still
FC.
symptoms are there, you have to do a
Okay,
fraction.
that's fair enough.
You are all experts in hysteroscopy. All of you are.
You will try to move in from
you can say
less
my grey
invasive
hair
to.
permits me to do a DNC, not
No, madam, if you can get tissue with PIPL, why go in for hysteroscopy? Why subject the patient to anesthesia?
If you don't get tissue with this, I mean, if the symptoms recur despite a negative PIPL, then you might as well do a
That's fair enough. That's a fair enough option. If you don't get tissue on PIPL, then they're saying that you can either go in for a hysteroscopy directed biopsy. If you're in a center where you don't have hysteroscopic facilities, go in for an FC then. Now, what did we do? Because she was already on progesterones, we gave her Primolute for 1 cycle to control her bleeding, and the next cycle we did a sampling for her. Her histopathology report was simple hyperplasia with atypia. What would you do? From this point, what would you do next, madam? She's 33-year-old, she's para-1, live-1, child is 8 years old. She's come to you, you've done a sampling, this is your histopathology report. How would you like to proceed? Sheila Shinoy, madam?
Whether she would like to have another baby, that's the first thing which we are to ask her.
She's not decided. She says she's not
She
sure.
has to decide. I think she has to decide.
Okay.
Now, because she is now 33 years, she cannot wait on and on. Her ovulation, her age of the ovum, one child. But if she wants to have a baby, it's better, and we can treat it and give her some drugs.
Suppose she says she does want to have a baby. What drugs would you like to give her?
No, something for correcting the atypia, medroxyprogesterone, high doses should be given.
give it for 6 months.
6 months.
Yes, ma'am.
Metroxyprogesterone. If you are giving metroxyprogesterone,
Okay, Shyamla, madam.
metroxyprogesterone give 200 milligram daily.
Hydroxyprogesterone 200 milligram.
Because hyperplasia with atypia you have to give, or you give megestrol acetate 40 milligram daily.
It's the other way around. I think megestrol acetate is what is in higher doses, 40 to 160, and medroxyprogesterone is 20 to 40 milligram per day.
20 to 40 milligram daily, and it has to be given for at least 6 to 9 months, and you have to re-evaluate the patient every 3 months.
They say give it for 6 months.
And then re-evaluate.
Wait for 1 month, and then after 1 month you do the evaluation. That's what they say.
So, see, if you have atypia, be very careful. If you can't keep the patient on follow-up, if the family is completed, think in terms of a hysterectomy. That's what all the guidelines say now. But if she has not completed her family, she needs some time to decide, she will be under good follow-up. You can give her medroxyprogesterone 20 to 40 milligram per day. Give it continuously for 3 to 6 months, 6 months at least minimum. Wait for a month. This waiting for a month is very important. Resample again and check. And that would be how you would decide further. Suppose the atypia is not reversing, then you would probably continue with the treatment. What do you suggest, Dr. Sheila?
Depends on the patient, isn't it? Most of the time, if they've had one child, they might say they want a, if they want a history. I think many of them would say, I mean, they have one child, so they might be willing to go for a
Right,
hysterectomy.
so if it doesn't
Depends,
revert, she might actually go in for
it's
a
not as if
hysterectomy.
she doesn't have children. Is it?
Okay. If she has no atypia, what they say is you have all these options. If she's trying for a child, you can even give her ovulation induction. You can give her medroxyprogesterone. You can give her cyclically. They say you can give her continuous. All these are various options that you have. What I am showing you now is when there is no atypia. What I showed you earlier was when you have atypia. When you don't have atypia, you can offer them ovulation induction if she wishes to conceive. You can give her OC pills and you can give her medroxyprogesterone for 3 to 6 months. Resample again. And what do they say? They say if it is persistent change, continue with the high dose. Like if it's still showing simple hyperplasia, it's not reverted, continue with the high dose. If her changes have reverted, discontinue treatment but follow up. Very essential. Now, I found this very interesting thing. I found this little picture when I was looking up some literature for this, which showed micronized progesterone, medroxyprogesterone, megestrol acetate, and levonorgestrel. Now, what is your opinion on using a levonorgestrel intrauterine device?
Simple hyperplasia, you can use it.
Simple
In
hyperplasia?
simple hyperplasia.
If you have atypia? Anybody who would like to take up the question?
Yeah, no.
Mike.
ATP you need higher doses, so that much dose will not be delivered by the LNG.
Okay.
Simple hyperplasia LNG is okay, but severe hyperplasia you have to give higher doses of hormones.
Okay. If you have, suppose your changes of atypia have reversed on 6 months follow-up, 6 months of high dose, And now if she wants LNG, would you give it to her?
Yes, we can give.
Fair enough option. Okay.
Because rather than taking orally, it will be available in the uterine
Correct.
environment, and the ill effects of oral tablets are not there. So
Okay.
it's always better to go for LNG device, which will be useful.
Okay. So the important point is you're not giving LNG as first line. You're always giving oral. That's what you're saying. Right?
Oral we have given for some time, and then we
Yeah,
are now.
then you can. So it's like a second line thing that you're giving. Okay. Now, what does the Cochrane review say? They say that there is no evidence available from RCTs regarding the efficacy and safety of the levonorgestrel intrauterine system for a typical endometrial hyperplasia. Now, see, this Cochrane review has to be really analyzed carefully, because what they say is you don't have randomized control trials. That is the reason why they say there is positive evidence. There are a lot of studies which say that there is actually, it could be used, but use it with caution, because even now there are no RCTs. Would you suggest tranexamic acid to arrest bleeding in her? Stop. Radha Kumari, madam,
Or not?
before you have done sampling or anything, she's come to you with acute bleeding like this. Would you suggest tranexamic
No,
acid to
it's
her?
not going to be this thing. In
Correct.
an anovulatory patient, it's unlikely to be of any help. You do an endometrial thickness and you find that it's a thick endometrium, your tranexamic acid.
So
Usually
who's
in
the
an
patient for
anovulatory
whom,
PCOS, only
which
hormones will-
patient would you suggest tranexamic acid for?
Ovulatory. I mean, when you have regular cycles and they come with heavy menstrual bleeding, those are the patients where you go.
So that's a very important take-home message. See, don't be tempted to start tranexamic acid and your mefenamic acid for every patient who comes to you with irregular bleeding or heavy bleeding. If it is regular heavy bleeding, you can give her. If it is not, do not try tranexamic acid. She needs hormones. See, again, this is the Cochrane review. It says tranexamic acid is effective in reducing heavy regular. That's the most important word, heavy regular menstrual bleeding. What is your opinion on Novex DS or meloxifene? Anybody who would like to take up that question?
It has been found very useful in puberty menorrhagias.
Okay. What about this age group, madam, 33-year-old who's been started? What is your criticism or your comments on it?
Not
I
Would
am
you
not
have started? Would you put your patients on ormeloxifene?
Not tried, but in the puberty menorrhagia group I have tried, I found it very
See, the main problem with ormeloxifene is that there are no trials at all. That's one important
Correct.
problem. The second thing is it's a SERM. You don't know how SERMs will act. They can either act this way or that way. That is the main problem. So I'm not at all happy using Novex DS in any patient because I don't know how they act. Especially in a patient with polycystic ovarian syndrome, you can find after some time, you can find a very thick endometrium. I mean, accidentally I found somebody had given Novex DS for quite some time for a patient. She came back with a 30 millimeter endometrium, very thick endometrium. So this is something which, because they can act in any way, you don't know, can act as an agonistic action or an antagonistic action.
It goes for malignancy.
I
That
don't know.
I have
Some
seen,
of them do respond. I do agree, some of them. But unfortunately, we do not have any evidence also.
But I have used for perimenopausal women, and it is found to be under follow-up. You can give, and it,
Puberty menorrhagia patients, they are quite happy because it's the parents who are giving the child the tablet and it need be given only 2 days a week. And
Right.
usually after 3-4 cycles, their hormone level becomes normal and they get over that phenomenon.
So there's probably convenience in all in using it, and whatever literature I looked up, majority of the trials were from India. There's no Cochrane review, nothing. As yet, I wouldn't really recommend it per se, but there's a lot of senior people with experience. The decision is left to you. There is no data, there's no trial supporting it. I'm sure you would not recommend any of these, would you? You have endometrial ablation, TCRE, danazol, GnRH agonist. Right. So, okay, agreed. Now, I'll just skip to another interesting. This is the scenario.
Without ATP, why not do ablation?
More invasive, madam.
If she has hyperplasia, your question is why not do ablation, madam?
No, there is no, you said there is no atypia.
There is no atypia, but she has irregular anovulatory cycles. In endometrial ablation, what they say in the beginning itself is ablation is recommended for regular heavy bleeding women. That's the first thing that they say. For anovulatory, they say you just need to give her progesterones and it'll control, so don't go in for endometrial ablation. Pathology is different. So they say no need to go in for endometrial ablation. So shall we just move to the next scenario? This is just another point to highlight to the audience. She's a 57-year-old lady. She's postmenopausal. She had her menopause 2 years back. She has one child. 4 years back, a scan was done for her and she had adenomyosis. She came for checkup. She just wanted a gynec checkup. She had a smear, she had a scan. Scan showed endometrial thickness to be 9 millimeter and adenomyoma of 5 into 4.7 centimeter in the posterior wall, and both ovaries were low volume and normal. Endometrium is 9 millimeter. Would you sample? She's
not having a
asymptomatic.
postmenopausal bleeding.
Nothing. She's asymptomatic, but she's 9 millimeter endometrium,
No,
and
we
she's
have
just
to-
read
I
in the
think we
net
have to
that.
sample. We want to find out what is happening, why the endometrium has become 9 millimeters.
So you feel sampling is required. What about you, Radhakumari madam? Would you sample?
I also-
Sample. Sheila madam?
How old is she? Came with
She's 57, menopause 2 years. She has no symptoms at all. She's
Why
asking
did she
you
come to you?
gynec checkup. She wanted a
for a
gynec checkup.
This is a very difficult situation. That's a problem. We don't know.
Would you sample Shamla madam?
All the
What
books
do
say
you
not to
We can
sample,
keep-
but
no,
personally
we
I
can
don't
keep
know.
her under observation, ask her to come for follow-up.
Correct. I think what Shamla madam has said is what. See, we also went ahead with a sampling because we were also worried about the 9 millimeter. We did not get any tissue. Probably, we had made some error while doing the ultrasound. Maybe it was not really 9 millimeter. Anyway, we advised her to report after 1 year. What is the recommendation? Now, this is what is most important for the audience. Endometrial sampling in a postmenopausal woman without bleeding should not routinely be performed. Indications for endometrial sampling in bleeding postmenopausal women with endometrium more than 4 to 5 millimeters should not be extrapolated to asymptomatic women. So just because you find an endometrium more than 4 or more than 5, understand one thing, if she is asymptomatic, that criteria does not apply. The criteria of 4 to 5 millimeter cutoff applies only if she is bleeding. What do they say? Endometrial thickness with positive findings on ultrasound. Suppose you get increased vascularity, inhomogeneity of the endometrium, particulate fluid, or thickened endometrium over 11 millimeters. Then, this is the Western Society, they say then you refer to a gynecologist for further evaluation. So that further evaluation there would probably be sampling. And decision is further, even then they say more than 11 with all these findings, then even then they say you make your decision on a case-by-case basis in asymptomatic women with increased endometrial thickness and risk factors for endometrial cancer such as obesity, hypertension and late menopause. So remember, up to 11 is almost safe provided you have no other factors, she's asymptomatic. Suppose she has those other findings on ultrasound, what I mentioned here, and she has these risk factors, then maybe you're justified in sampling beyond 11 millimeter. That's all. Thank you. Thank you to all my panelists.